thickness in the PRP group was 24.43, in the minoxidil group 29.95, and in the microneedling group 23.79. The mean hair thickness increased by 2.26 micron in PRP group, 8.76 micron in minoxidil group, and 1.77 micron in microneedling group. The mean hair density in the PRP group on the first visit was 101.36, in the minoxidil group 101.36, and in the microneedling group was 101.6. On the last visit, the mean hair density was 111.12, in the minoxidil group 104.23, and in the microneedling group 108.35. The mean hair density increased by 9.76 in PRP group, 2.87 in minoxidil group, and 6.75 in microneedling group. 12.22% of patients perceived total stoppage of hair fall after the last visit with maximum benefits in the PRP group. 50% of patients perceived reduced hair fall with maximum benefit in PRP group and minimum in minoxidil group. 26.67% of patients perceived no change in hair fall, and 11.1% patient perceived increased hair fall with 10% in microneedling group, 20% minoxidil, and 3.3% in PRP group. So this is the image showing pre and post procedure in the PRP group and minoxidil group, and these are the pre and post procedure and pictures in PRP group and minoxidil group. So in this study, there was statistically significant increase in hair thickness.
Continue.
In the hair thickness of patients PRP, microneedling group and minoxidil group, but the maximum increase was seen with minoxidil followed by PRP and microneedling. A statistically significant increase in mean hair density was observed in all the three groups. The maximum increase in hair density was seen with PRP followed by microneedling and minoxidil. PRP group patients perceived reduced hair fall and new hair growth, whereas minoxidil group showed a perception of increasing hair fall with moderate new hair growth. Microneedling also led to improvement in hair density. And these are the references.
Thank you. Thank you, Dr. Pragya Chaudhary, for finishing on time. Next up is Dr. Gargi Dakar. Dr. Gargi Dakar. Yes, you can. Whenever you are ready, tell us. We'll start the timer. A bell will be rung at 5 minutes. So instead of the thump, there will be the bell. If you are ready, just give us this thing. Start.
Good morning everyone. Today I am presenting a paper on the comparative study of POVA therapy and NB-UVB therapy in the treatment of vitiligo. Aim of my study is to compare the efficacy and safety of POVA and NB-UVB therapy in the treatment of vitiligo vulgaris. My objectives are to study the time taken for initial repigmentation, to study pattern of repigmentation, mean grade of treatment response, and color match of repigmented area with the normal skin, and to see if there are any side effects of the treatment and during follow-up. Coming to material, it was a randomized controlled trial carried over a period of 12 months in a tertiary care center. My inclusion criteria are all patients with stable vitiligo, having vitiligo for more than 1 year, with age group of 18 to 65 years, having body surface area involvement more than 10%. Exclusion criteria are patient taking any drug causing photosensitivity like hydroxychloroquine, retinoids, and fluoroquinones, history of any photomediated disorders, any history of previous skin malignancy or any renal or hepatic diseases, pregnant or lactating females, or patient on any topical, oral, or surgical treatment for vitiligo within previous 6 months. After the patients were selected, detailed history was taken regarding the age of onset of vitiligo, course of the disease, stability and rate of progression, potential precipitating events, cutaneous trauma history, history of photosensitivity and drug causing photosensitivity history, and history of any treatment and family history. Detailed examination was done for the size, shape, number, color and distribution of the lesions. After that, laboratory investigations were like routine blood examination, urine analysis, blood sugar, blood urea and serum creatinine, LFT and thyroid function tests were also done. Initial photographs were taken before the treatment, photographs were taken completion of every 16 treatment session and at the end of the treatment. Patients were randomly allocated in two groups to receive either PUVA or NB-UVB therapy by the mean of a sequentially numbered list. Patients were divided into two groups. Group A was given, a patient was instructed to ingest trimethylsoralin 25 mg tablet on empty stomach 2 hours before UV exposure. Standard initial dose was 3 to 5 joules per centimeter square and therapy was administered twice per week, increased by 0.5 joules per week. Group B was given, patient was received initial dose of 250 millijoules per centimeter square of NB-UVB. Therapy was administered twice per week. Dose were increased by 50 millijoules per centimeter square per week. During each treatment session, patients were instructed to shield their genitals and use photoprotective goggles. Coming to assessment of the treatment, repigmentation was graded in each topographical area as follows. Grade 0 was no response, grade 1 is very poor response, grade 2 was poor response, grade 3 was good response, grade 4 is very good response and grade 5 was excellent response. Termination of therapy was done when there was 100% repigmentation or 12 months period was completed. Coming to my results, first is distribution of the cases according to initial time for repigmentation. As we can see here, in the group, in the NB-UVB group, that is by the blue color, and the orange is PUVA group. Initially, in the NB-UVB group, repigmentation was more significant, but later on the difference is not significant. Coming to comparison of mean grade of treatment response between NB-UVB and PUVA group, as we can see here, a significant difference was seen initially at the 5th month, both in NB-UVB group and in PUVA group. Later, the difference is not significant at the coming to distribution of cases according to color match of repigmentation with the surrounding skin. In the NB-UVB group, 85% patients had same color match, while in the PUVA group, 75% had same color match. Coming to distribution of cases according to pattern of repigmentation, both groups NB-UVB and PUVA groups has 50% of patients had diffuse repigmentation, and in both groups other patients were in follicular and marginal pattern of repigmentation. Coming to distribution of cases according to side effect, as we can see here, burning and itching was seen more in NB-UVB group, while the nausea and vomiting was seen more in PUVA group. These are the pictures showing patient with NB-UVB therapy at the start of the treatment and at the end of the treatment. Next picture is patient after PUVA treatment. Coming to summary, this comparative study was conducted to compare the safety and efficacy of PUVA and NB-UVB therapy in the treatment of vitiligo. There was consistent improvement in the treatment response in each group from onset as the duration of treatment increased. At the end of 5th month, the mean grade of treatment response was slightly better in NB-UVB group compared to PUVA group. However, it was statistically not significant. At the end of the treatment, mean grade of treatment response in NB-UVB group was higher than in the PUVA group. This difference was statistically significant. The color match same as that of surrounding skin was seen in 85% of patients in NB-UVB group, whereas only 75% patient in PUVA group. This same color match is cosmetically very appealing to the patient and it increases the psychological satisfaction of the patient. Thank you.
Thank you, Dr. Gargi Dakar, finishing well in time. Dr. Prakriti will be up next, and Dr. Rishikesh is around. Yeah, you will be last. So we have 2 more people to go. Dr. Prakriti, when you are ready. Your time starts now.
Good morning, everyone. My lecture is on study of effect of autoinoculation in immunotherapy in plain warts. Introduction. Viral warts are papillomas caused by human papilloma virus and can grow anywhere on the body. Clinical types of warts seen are common warts, plantar warts, plain warts, filiform and digitid warts, and anogenital warts or condyloma acuminata. Management is difficult, primarily due to recalcitrance to standard therapy and high recurrence rates. There are various methods for treating the warts. They have been tested all along. These methods are intralesional injection of bleomycin, MMR antigens, cryotherapy, laser ablation, electrocautery, surgical removal, candida albicans,
or PPD. The need for immunotherapy that can target remote wards, that is those which are not intervened directly, is felt by all practicing dermatologists, especially in cases of multiple wards and wards at inaccessible sites. Immunotherapy can overcome the limitations of conventional ablative therapy by resolving lesions distant from the site of administration as well as subclinically infected virus tissue, thereby making it a preferable choice for the patients with multiple wards and those with wards at difficult to treat sites. Autoinoculation as immunotherapy for wards seems to be an inexpensive and effective treatment modality. Aims and objectives are: aim was to study the effect of autoinoculation immunotherapy in patients of plain wards. Objectives are to study the number and proportion of clearance of lesions within 3 months of follow-up of autoinoculation immunotherapy in patients of plain wards, and to study the adverse effects of autoinoculation immunotherapy in patients of plain wards during 3 months of period. Materials and methods. The place of study was carried out in the Department of Dermatology in MDM Hospital, Jodhpur. Study design: this was a hospital-based single-arm interventional study. The total duration of the study from the acceptance of proposal of study till the completion of thesis was 7 months. And study population: all the patients were in the age group of 18 to 60 years with plain wards attending the skin OPD at Jodhpur. Methodology: sampling methods: quantitative sampling of the OPD patients after informed fully. Selection criteria: patients will be selected by applying following inclusion and exclusion criteria. Inclusion criteria includes patient with more than 5 plain ward lesions, age between 18 to 60 years, no concurrent systemic or topical treatment for plain wards, and patients giving consent for autoinoculation. This is a performa for cutaneous examination. It was at the patients were followed up at first month, second month, and third month. Autoinoculation immunotherapy administration. Patients attending the skin OPD in MDM Hospital diagnosed clinically with plain wards and selected according to the above inclusion and exclusion criteria. Then detailed history of each patient was taken and recorded in the performa designed for the study regarding name, age, sex, occupation, marital status, residence, mode of onset, duration, number of lesions, and progression of the lesion. Now, the selected patients had undergone autoinoculation immunotherapy as explained below. The procedure was performed in skin manual OT under strict aseptic conditions. In those patients with plain wards, the index ward, the largest and the thickest lesion, was selected for treatment. After cleansing with surgical spirit, infiltration with 2% lignocaine was done. A fresh surgical needle, 26 gauge, was used to puncture through the lesion repeatedly up to the level of subcutaneous tissue. Each puncture was just enough to produce pinpoint bleeding. This was continued till no more resistance or reactive pressure is felt from the abdomen. The endpoint is to produce a deeply red wound. The number of punctures varied according to the size of the lesion, average number being 20 to 30 per centimeter square. Firm pressure was applied to the wound till there was no active bleeding. To induce a successful controlled inflammatory response, each patient was advised to avoid taking NSAIDs drugs for 48 hours. This table shows the distribution of age in years. In less than 20 years, 5.9% of the patients were present. In 21 to 30 years age group, 47%. In 31 to 40, 43%. And greater than 41%, 41 years, 33.5% of the patients were present. In the study, there were 43.5% females and 56.5% males. The site of lesions: 82.4% of the lesions were mainly present on the face, 17.6% were present on the hands. The mean number of the lesions of the patients were 12.1 plus minus 7.05. This table shows reduction in the number of the lesions in the first month was 2.2. In the second month, the reduction in the number of lesions was 9.9, and the mean reduction of lesions in the third month was 10.8. The mean reduction in proportion of the lesions in the first month was 18.9, and in the second month it was 82.0, and in the third month the mean reduction in the proportion of lesions was 8.3. The adverse effects: there were in 71.8% of the patients there were no adverse effects. In 5.9% there was pain with needling. In 18.8% there was PIH. In 3.5% there was secondary infection. These are the slides showing the at day 0 and at 2 months, at day 0 at 1 month, day 0 at 3 months, at day 0 and at 2 months, at 1 month and 2 months. The study was undertaken to evaluate the efficacy of autoinoculation immunotherapy in terms of reduction in number and proportion of the lesion at first, second and third month of follow-up. The study involved a total of 85 cases. Among all these cases included in the study, majority of the patients 82 point had lesions on the face. Most of the lesions, patients had no adverse effects. Reduction in the number of lesions in the first month was 2.2 and in the proportion it was 18.9. Conclusion: the conventional modality in the treatment of warts, including destructive therapies, are cumbersome in nature and typically require multiple sessions with individual treatment of each wart associated with various.
Your time is up.
Thank you, sir.
Okay. Thank you. Dr. Rishikesh will be the last of the candidates for the award paper session. So when you are ready, tell us. We'll start the counter. Are you ready? Your time starts now.
Good morning to all. My topic is on dermoscopic findings in vitiligo with emphasis on disease activity and observation study in a tertiary care center in East India. Coming to the introduction, vitiligo is an autoimmune disorder of pigmentation. There is loss of functional melanocytes and melanin from the epidermis. It affects 0.3 to 1.1% in the world population, and normal skin has a reticulate pigmentation pattern which is altered in vitiligo lesion. Dermoscopic examination is useful in early diagnosis of vitiligo and to assess the disease stage, evolving, stable or repigmentary. Now, vitiligo causes significant cosmetic disfigurement and also affects the psychological well-being. Dermoscopy is a non-invasive handy tool used to examine lesions in vitiligo. It helps to understand the disease activity and the stage and identify early vitiligo lesions. There is a need to validate many reported dermoscopic findings for universal use. Coming to the aim, to observe various dermoscopic findings in vitiligo and the correlation of the findings with the disease activity. Coming to the materials and method, institution cross-sectional study, a sample size of 50 clinically diagnosed cases of vitiligo, informed consent and detailed history were taken, clinical and dermatological examination were done. Baseline data were collected. Patients were divided into three groups: stable vitiligo, unstable vitiligo, and patient on treatment, which includes both stable and unstable vitiligo, as per clinical classification of disease activity, based on the disease stability being defined as a patient reporting no new lesions, no progression of existing lesion, and absence of commoners phenomena. Confidentiality of the patient was maintained. Dermoscope AM7013MZTS Forest Dino-like Premier was used. Coming to the inclusion criteria, those who are consented for the study, any age group and sex, free from any systemic disease, work with new vitiligo lesions or patients who are receiving any therapy for vitiligo. Exclusion criteria being unwilling patient, history of malignancy, any other cause of hypopigmentation and depigmentation. Here is the diagram showing the A showing the normal pigmentary pattern, B perifollicular hyperpigmentation, C perifollicular pigmentation, D perifollicular depigmentation, E reduced or absent network pattern, reverse network, G leukotrichia, H1 showing polka dots, I showing microcommunal phenomena of satellite lesions, comet tail pattern next, then K showing perilesional marginal hyperpigmentation, then next starburst pattern, and showing trichome pattern, and showing erythema with telangiectasia. Now here's the dermoscopic images which I have taken. First showing perifollicular hyperpigmentation, where around the sebaceous orifice there is hyperpigmentation. Marginal hyperpigmentation showing at the margin there is increased pigmentation. The reticulate pigmentation couldn't get this image clearly. It is within the vitiligo there are reticulate network of pigmentation. Coming to this thing, comet tail, there is microcommunalization along the line of trauma. There is hypopigmentation. Then trichome pattern, where inner you will see white, outer a fade of yellow, and external to it you will see the normal skin color, showing a 3-color pattern, that is trichome. Then there is polka dots, that is satellite lesions. Here showing there it is erythema along with repigmentation idents. then leukotrichia, and a reduced pigmentation network with a black arrow and ill-defined borders showing the green arrow showing ill-defined borders. Actually, this is a very cumbersome table. I have simplified it to a pie chart. So actually here you can see the first three, mainly stable vitiligo. Mainly what we see is marginal hyperpigmentation, perifollicular hyperpigmentation, reticular pigmentation, whereas the below three shows mainly majority is unstable vitiligo showing trichome, common tail, starburst, and polka dot, perilesional perifollicular depigmentation, and reduced pigment network. Whereas eczema and telangiectasia is mainly seen in patient on treatment. Here is the result, which I know mainly in stable vitiligo means marginal hyperpigmentation, whereas in unstable vitiligo it is a trichome pattern, common tail, and vitiligo on treatment. Actually, all findings are seen plus eczema, telangiectasia seen. The dermoscopic findings of this study are in full agreement with study by Wali et al. And Nirmal et al. Mixed findings were observed by Jha et al. Were in progressive vitiligo, there is perifollicular pigmentation and alteration of pigment network were most frequent in stage. Dermoscopy is a non-invasive diagnostic tool that facilitates a clinical approach to vitiligo and allows clinician to treat it according to its stage. Marginal hyperpigmentation, perifollicular pigmentation, reticular hyperpigmentation suggest stability, and patterns like trichome, starburst, common tail, polka dot suggest instability.
Like the sex distribution, there is also the exclusion criteria can be shortened so that we, and also in the introduction, we are all the medical doctors, so we have not to take all the elements in account because yes, we know already, but and you lose a lot of time that we cannot discuss the conclusion because what is the most important thing of the paper is the data and the conclusion. And where and the take-home message, how we can improve, and that all candidates lost a little time of that. So you have to shorten the first part and to then into the next part. And I know it's stressful. I was there also once, so I know it very well. Thank you very much.
Thank you all the participants of the session. It was really very good. We come to the next session, but the session will slightly be postponed because our great person, Dr. Brijesh Nair, has to catch a flight. So I request him to go to the dais, and I request Dr. Shreya Kamath to chair the session and Dr. Sanjay Singh to chair the session, please. Dr. Sanjay Singh and Dr. Shreya Kamath will proceed. Thank you.
हेलो हेलो हाँ हेलो हाँ भैया बोलिए हाँ हाँ चालू है प्रोग्राम तो आज 10 बजे चालू हुआ है, लेकिन हम लोग 9 बजे आए थे। यहाँ पे तो कुछ नहीं था, कुछ भी नहीं था। 3-4 बजे तक तो बोलना है। क्या भैया? जी 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 तो बात कर लीजिएगा जब चाहिए आपको, तो पेन ड्राइव में दे देंगे। हाँ तो डाटा पेन ड्राइव दे देंगे तो आपके पास ही रहेगा।
Check, yeah.
Hello everybody. Although we have a slightly lower attendance, but we are going to discuss a very vexing topic which begins right from infancy to pre-adolescence to adolescence, then it goes into early adulthood, and now even sometimes in middle ages. We also will be discussing newer modalities, including pathophysiology, and also a new spin on the traditional topical therapies and systemic therapies. And we have a very accomplished speaker and an academician and a regular at most of the conferences, Dr. Brijesh Nair. My fellow co-person will introduce me.
Brijesh, how do I introduce you?
Hello. That's all that is required.
Brijesh is an old and current friend. We worked together in IGDVL, where he was in the editorial board, and he used to love case control studies. Do I remember correctly?
I know.
Yeah, and we used to have
Right.
lengthy discussions on that.
Exactly.
And he is one of the apostles of EBM in dermatology. Today's topic seems to slightly deviate from it, but I am sure Brijesh will add a dash of EBM into it. So here is Brijesh for you.
Thank you. It's indeed an honor to be introduced by my good friend Professor Sanjay Singh. I'll at the outset thank Professor Arun Datta, who single-handedly mounted this whole thing. Dr. S.C.S. Sarkar, the scientific chairperson, Svetlana, who was hosting it. Let's not forget her also. So it's been a fantastic event, a very adhyatmic visit. And I have visited so many temples. I have never visited so many in any conference till now. So let's progress to the talk. At precisely 15 minutes, give me a cue to stop. I'll stop. So the talk is going to be about future modalities. I think this is not working, so So the sebaceous gland has often been mentioned as a living fossil with a past but no future. It's absolutely wrong. There are few cogs or domains into which I would like to break up this thing, and it is about the future lines of therapy that we are talking about here, not what is already known. So mostly we'll be discussing some newly approved molecules. First is the inflammatory response. Inflammation precedes the microcomedon. That's why I placed immune response on top. Hyperconification of the pilosebaceous duct, colonization and dysbiosis by C. acnes, increased sebum production, and altered sebum composition. It's not about the content alone, it's the quality of the sebum. Dysregulation of the cutaneous endocrine microenvironment. These are the 5 broad things, cogs, onto which I will always think in terms of acne. And then there are many other cogs. Let's not go into these details. You can click the photograph and keep it. This will all be maybe addressed in the future things. Coming to the first domain, that is immunology and inflammation. Acne scarring is all about inflammation. If there is inflammation, there is scarring. So we know that P. acnes acts as a pathogen-associated molecular thing, and it activates certain TLR receptors. I'll keep it very brief. And it also activates certain cytokines downstream. And this results in the microcomedon. This is a more representative slide where you can see that there are certain C. acnes which activate the MHC2 complex, and then there is the other aspect of the C. acnes, that is a virulent C. acnes, which activates the TLR. Now we are only talking about Th17 MHC initially, but now we have to talk about the inflammasome, the NF-kappa B pathway, and the IL-12 pathways also. Just these are broad outlines which I thought I should give to you. I will not go into the details of this pathways, which will be very boring. So now there is this thought process is that acne, it fits into the characteristics of an autoinflammatory keratinization disorder. Altered keratinization, inflammation, correct? With a good component of IL-1A and IL-1B. Why am I harping on IL-1A and B? Because that is the hallmark of autoinflammation, correct? So expression of IL-1A is important. TNF also has a great role to play in acne. 5-lipoxygenase, leukotriene A4 hydrolase, and COX-2. 3 underutilized targets for acne. There are a lot of molecules which are under study. One is obviously Ziluton, which is targeting 5-LOX. So let's go into the therapeutic options. Why are we discussing all these names? TNF, IL-1 alpha, what the hell? What's the point? It's targets. These are the therapy targets. You have TNF inhibitors. Have you ever tried TNF inhibitors in your worst cases of acne conglomata? You should. Adalimumab, etanercept. Because there is scientific proof for it. Resistant cases with syndromes like Papa syndrome, Sappho syndrome. You have arthritis with acne. You also have very severe acne also. You have acne with HS. There you are using isotretinoin in this thing. So why not use TNF inhibitors in your worst cases, the nightmare cases of acne? Because there is evidence here. Among the IL-1 alpha and beta, IL-1 beta actually failed miserably in trials. There are molecules targeting IL-1 beta. But then there is a biological in IL-1 alpha, which seems to be the more relevant cytokine, and a molecule called bermekimab. IL-1 RA anakinra has been tried in syndromic acne things, that is Papa, PASH, all those syndromes. Then there are certain other components which are COX-2 inhibitors, Ziluton, which is a LOX inhibitor, leukotriene A4 hydrolase inhibitor called acebulostat. Just click these because these are going to be the future approval molecules. Either they will fall by the wayside or they will reach the approval stage. Ingenol disoxate, P38 MAPK. If you saw that pathway, there was that P38 MAPK. The problem with P38 MAPK is that it's got a lot of baggage, hepatotoxicity. When you inhibit P38 MAPK, you are hammering a lot of cells. And off-target side effects can be very common. More so than even tofacitinib, the JAK inhibitors. Now the second domain. Quickly into the second domain, we know that it is the content of the sebum which changes. Actually, the sebaceous gland atrophies in acne. We don't think of a thick, lush sebaceous gland in acne. Isotretinoin is the one thing which works. It does everything correctly. Correct? There is no doubt about it. Now triferotin has been approved. We have all listened to the lectures on triferotin in various sessions, mostly driven by the company itself. It's supposed to have less irritant action than the other retinoids. It's a 4th generation retinoid. It's also been touted as a molecule for CTCL, localized CTCL. Azarotin in short contact has been used by us 10 minutes and wash off in comedonal acne. How many of you have used it? There are 1 or 2 arms which are coming up. Now we have a better option in the pipeline, that is a lower concentration, which might help you to tolerate the molecule better. Third is the micro, that's the third of the 5th domains. Again, it is the quality of the Cutibacterium acne. Certain clades make you more prone to acne. It's not all C. acnes causes acne. And it produces porphyrins, plays a role as a super antigen. These are various theories. And then most importantly, the biofilm, which makes it very resistant to therapy, and resistance to molecules are faster to happen. And it also produces these certain clades of C. acnes, produces lipases, proteases, hyaluronate, lyases, which causes all the damage. So it's not like a bombardment against C. acnes anymore. It's got clade targeting. And what determines the shift of the recognition of C. acnes? This is the $1 million question. Why should certain clades cause acne? Various theories are there. We are thinking of low-dose doxycycline. I'm really surprised why no one is bringing the 40 milligram Oracea tablets into India. Because it relieves you of that antibiotic resistance pressure and gets all the right things to be done. Correct? It addresses the inflammatory part of it without causing any resistance. So there are molecules out there in the West, 40 milligram doxycycline. It's a wonderful option if you can have it. We have 45 milligram minocycline, 65 milligram minocycline, which I use extensively for anti-inflammatory role. But minocycline carries a little bit more baggage. It can occasionally cause a stress also. The next is saricycline. Same thing. Less antibiotic pressure. It doesn't affect the gram-negative bacteria in the gut. And thereby, saricycline is a safer option and this is FDA approved. 2018. You must have already heard of it in some lectures. more than 9 years age. It will be launched in the Indian market, I think. Omeganin is a synthetic antimicrobial peptide of bovine origin, which has its action against various pathogenic acne-causing organisms. Minocycline 4% foam. India is always ahead of its times. We already have the gel. Whereas the research is on to formulate a 4% foam. It is so unstable. That is the problem. To formalize this foam is important. So the research is still on and is not reached the approval stage. But we have launched the gel. Topical tyrothromycin, adapalene and nadifloxacin combination. We already have it in the Indian market. It is only in phase 2 and phase 3 in the West. To combine these molecules stably, that is the main problem. Formulations. Pentobra, Zolam, 9-3% gel. Let's skip this. Let's not get into too much of this. Another important aspect is biofilm busters. You have to break the biofilms to prevent resistance, and biofilms drive the whole destructive process. Serratiopeptidase has been touted as an option. N-acetylcysteine has been touted as an option. These are easily available molecules in the Indian market. Salicylic acid gel, plain gel. How many of you are using salicylic acid gel? It is a biofilm buster. So it's acting as a biofilm buster in acne. We have certain biofilm matrix degradation gel in the works. Some other molecules like MDDO and mirtazine. Mirtazine is a natural active component containing myrtocomalones. So these are the biofilm busters. I thought I'll leave them out. Probiotics. This is the most exciting part of the future. How to drive out the pathogenic clades, how to bring in the good guys. Lot of options have been tried. Some of them are enumerated here. Nitrosomonas eutropha, Streptococcus salivarius. Lot of tongue twisting names. But the concept is what you carry. So this is an important domain. This is going to be an important domain in the future. And even personalized manipulation of our cutaneous facial microbiome might be a future option. Just like in inflammatory bowel disease. You have the fecal transplant, correct? Now the sebogenesis. How many minutes left? Another 5 minutes. So we have got adequate time. As I said, the content and not the quantum. This is the rough list of all the alterations which are seen in the sebum. So what are the molecules to adjust to target this sebocyte, which is the fourth domain of our lecture? Olumacosat glyceretil is an ACC1 inhibitor. It's a rate-limiting enzyme of sebaceous de novo fatty acid synthesis. This is one of the leaders in this particular domain. As far as the research is concerned, I think the phase 3 trials are on or they have just been completed. The results are awaited. Another thing which is exciting is the selective photothermolysis of the sebaceous gland. As you can see, this is not my slide. I have borrowed it from someone. And wavelength of 1726 nanometers. So there are certain lasers which are coming up, which will be, I don't know whether they will hit the Indian shores, whether the expense factor will be a limiting factor for this, but this is the wavelength, and there is sapphire cooling which prevents overheating of the epidermis. So this is another approach, selective photothermolysis of the sebaceous glands. And we have certain pivotal studies also, where 104 subjects have been studied, 1 month apart sessions, 30-minute laser treatments, and primary endpoint was achieved by 50%. It is a good add-on to whatever your regular therapies are. Physical modalities cannot be considered the prime mover in any therapy, but it is a definite add-on. Like you have laser hair removal in hidradenitis suppurativa. I advise it for every patient who can afford, even at stage 1 of HS. It helps. Sebocyte regulation has also been surprisingly done by alpha MSH. We have that alpha melanotide, if I'm not wrong. And then there are certain PAR regulators also which control the sebocytes, although these are pretty early days for that. Coming to the last domain, that is endocrine dysregulation. There are two molecules which I wanted to discuss here. One is spironolactone. It's a proven anti-androgen, works in the peripheral androgen receptor level as well as the central level. It's a beautiful molecule for hirsutism. Now they are also trying to market it in microemulsion format for acne. The other drug which is already FDA approved is clascoterone, which is also known as cortexelone 17 alpha propionate. It's a peripherally selective anti-androgen, local anti-androgen effect is greater than progesterone, flutamide and finasteride. So it's a potent molecule. Safety has been studied over the 9 years. It's now FDA approved. Greater reduction in inflammatory lesion count compared to placebo or tretinoin. So tretinoin is kind of like a gold standard for us, right? Better tolerability is the main advantage with clascoterone. So people who are not able to tolerate your topical isotretinoin, some people can't tolerate azelaic acid. If you have seen, some people get irritated by that. Salicylic acid can cause a little bit of irritation in some. This might be a very good option. So the last slide. This is the slide which you can ignore. This is the slide which you may ignore because this is molecule. This is deep diving into the pathways. Or you can click this and maybe do a little bit of side reading at your end as to how this affects. Like WNT antagonist agonism is a countered thing for androgenetic alopecia, correct? Similarly, WNT agonism is whatever is on the left side is the agonist. So if you agonize these things, acne will improve. If you antagonize the pathways on the right, that is in the red, it will aggravate your acne, correct? So this is the way antagonism of certain pathways and agonism of certain pathways will in the future hopefully lead to more successful and robust therapeutic options because ultimately acne is our bread and butter. Thank you.
Truly an educative talk into the pathophysiology and timely interventions and newer insights into the emerging therapies. So we will take one or two questions from the audience.
Do ask questions, no? You won't get a better speaker on it.
Maybe they are overwhelmed with data, new data, and they are soaking it in.
I could also get maybe about 40% of it.
This is the way. See, the pathway delineation, that is the future of all diseases. These pathways initially were all theory for us. It's no longer. These pathways which are differentially expressed between certain organs and certain other organs, because you cannot have a pan. P38 MAPK ka sabse bada problem is, it's like a carpet bomb. It's like there in every cell. We are looking at basically molecules in various disease pathways which are only expressed in the target organ with minimum collateral expression. And that is the hunt. That is where all the people are hunting. Intracellular, small molecules.
I have one question.
Yeah.
Is there any study regarding the duration of application of thyroid in acne?
See, what I do was 5 minutes to 10 minutes, not more than that. Maybe this 0.45%, there is not too much of literature around it. I did search. It was just mentioned in brief in one of the lectures given by a foreign presenter. I presume this should be like an overnight preparation?
Because 10-year application may be not sufficient for the activity.
Correct.
But there must be some study, good study regarding the duration.
Absolutely. The research is on.
We have done one study, although that is not published. Half an hour application of topical was found to be equally effective as the 12-hour application.
Wonderful.
But 10 minutes, I am not sure.
Yes.
That's why I am asking for it.
I am looking forward to this particular lotion getting launched in the market. We should all, because comedonal acne ultimately is a lot of resistance, isn't it? Even isotretinoin doesn't work that well there. So that's why you need it.
Thank you for the nice presentation.
Thank you. Yeah. Please.
Adalimumab.
Absolutely. We combine isotretinoin with adalimumab in hidradenitis suppurativa with acne scenario. And plain hidradenitis also.
Isotretinoin?
20 milligrams of isotretinoin is what I prefer. Adalimumab is the regular 80-40. Although the recommendation is 160-80-80. Cost factor being a limiting factor, I start with 80 and then I go to 40 every bi-weekly. And then I increase the gap. Isotretinoin helps me increase the gap between adalimumab injections to 1 monthly. So this same concept can be used in your isotretinoin resistant, very severe disfiguring comedonal acne also. Because TNF alpha is one of the most important things which are guiding conglomerate acne.
What
I
are
hope I
the
have answered your
patient's
question.
criteria for which you select isotretinoin along with adalimumab, and is there any special, like you will treat patient for 3 months with isotretinoin, if you don't get response, then you will start
I
adalimumab?
do not start for every case. I start for the very worst isotretinoin resistant cases. That will amount to around 1 in 100 patients of all the patients I select for isotretinoin. That is the scenario that you can think about. In addition to that, one more suggestion, folliculitis decalvans. That's a very resistant condition to treatment. Again, TNF inhibitors can be tried. I have tried it in 2 to 3 cases, it works fantastically.
Any before starting any adalimumab and isotretinoin, any prior investigation you do?
Absolutely. You do all the baseline tests for isotretinoin and all the tests for biological. Correct. I thank you all for patiently.
Thanks. We end this session.
Thank you very much. I request the chairpersons and Dr. Vijesh to go to that corner, and Dr. Barnard will present you with the memento. We come to the next session. Dermatologist surgery session. The chairperson will be Deepkara Pathak, Doctor. He is a professor and head of Kathmandu Medical College, and Dr. S.K. Singh is the head of Varanasi Medical College. One in the land of Vishwanath and another one in the land of Pashupatinath. They both will chair the session, and the first speaker in this session is Dr. Smita Ghate will present on the topic injectable PRF in dermatology. Dr. Smita Ghate.
Good morning to everyone. In the era of all the PRP, since yesterday we are listening the PRP's indication, there is a new concept which is coming up, that is platelet-rich fibrin. Now, what is a platelet-rich fibrin? So the story behind that, it is a necessity, is the mother of invention. So in France, because of all this limitation of the PRP, the use of anticoagulant can delay the further process of healing. Then it is a PRP is a multi-step centrifugation, means it requires to yield a good platelet. Minimum 2 steps of centrifugation is required. In few cases, there is a formation of autoantibodies to the bovine thrombin, and also the platelet PRP is only concentrated only the platelet, and it has removed the leukocytes. So it has taken only advantage of platelet and has eliminated the leukocyte advantage. Then in the PRP, the growth factors which is released, it is only for short period, means it is only for 1 day. And PRP preparation has so many protocols, everybody has their own protocol. So all these things was not uniform in preparation of PRP. In the France, there was a legal, to overcome the legal constraint, Dr. Chaucron, he is a dentist. He has taken a 10 ml sample and he has centrifuged it without any anticoagulant at 3000 rpm for 10 minutes. And he found this. He found this platelet rich fibrin in the center of the centrifuge, in the center of the tube. This is the actual picture of the PRF, and it is after removal. In the dentistry, they use this for the cloth, for filling the dead space in the teeth, and they also press it and make a membrane and use for the other surgeries. Now, what is this PRF? So this is a second generation platelet concentrate. PRP is a first generation platelet concentrate. It is a autologous and it is a platelet and leukocyte rich. We have taken the leukocyte also in the PRF. It contains all these platelet leukocyte growth factors. It promotes immunity and it releases the growth factor and cytokines for longer time. These are the content. It contains mainly the fibrinogen, which then further converted into the fibrin mesh rod. These are the list of the growth factors which is present in the PRF. The main function of all these growth factors is the angiogenesis, collagen remodeling, collagen deposition, and chemostasis, improves the immunity. These are the certain differences between the PRF and PRP. PRF, it requires only single spin, while the PRP, it requires a double spin to get the good platelet content. PRF doesn't require the anticoagulant, while the PRP requires the anticoagulant. PRF has the leukocyte, PRP doesn't have the leukocytes. And in PRF, the growth factors release is up to 10 days, while in PRP it is only a day. The same advantage, whatever is given, is the same. There are some disadvantages of PRF, that it has to be very fast, means because it is without anticoagulant, it has to be the entire process should be very fast before it goes into the clotting, and it cannot be stored because the risk of contamination is there, and because it is the yield, the quantity means 10 ml gives only 1 ml of PRF, maximum 1.5 ml of PRF. The Chowkron has also done the further this thing, that he has put the three protocols for the different things with the different RPM and the different with the same timing. And what he found, that as the RPM is decreasing, the yield of the leukocyte, platelet and growth factor is increasing. It is highest with the lowest RPM. There are many other studies has been done where the gravitational force has been decreased, either it is decreased or the timing is decreased. So there is a permutation and combination of by speed and time, and they have got the different types of PRF. So with the highest PRF, highest centrifugal speed (RPM) and the highest time, we get the LPRF. With the decreasing the centrifugation time, we get the advanced platelet-rich fibrin. And if we further decrease it to 700 RPM, we get the injectable PRF. So to get the injectable PRF, we have to lower down the RPM and even the timing. The PRF, which is reused in the dermatology, has the same indication as the PRP. It is better because it has more platelet, more growth factor, and also it has a leukocytes in present, and it used for longer time because the fibrinogen, which is in the liquid form, is further goes into the fibrin mesh, and all the leukocyte platelets get trapped in it. So the growth factors, cytokines, they are released for longer time, maybe up to 10 days. So these are the indications where we can use, where it has been used. I have few photographs, the clinical photograph. This patient has a scar of herpes zoster scar, and we have injected the PRF in her. This is her, the first is a PR. This is her pre, and this is a post. The visibility has been reduced to more than 50%. Here the front view. It has not completely gone after the 3 injections of GRF. This is another indication of periorbital pigmentation, where it is decreased. The scar, the improvement is not seen much. It is only the 1 injection has been given for this patient. It just shows the some lightening of this area. PDL line, pigmented demarcation line. This is the demarcation line which is seen, which is shows some decrease in it after the 2 injections. Scar again. This is a 3 every with the injection it has been taken. So this is a pre and this is a present. Even though the scar length means it is not completely gone, it shows that the scar is coming up. The refilling of the collagen is happening, and it is the depth of the scar is decreasing. Thank you.
Thank you, Dr. Smita, for a wonderful presentation. Any questions from the audience?
Thank you, Dr. Smita.
Gap between the injections was between the
1 month.
1 month. And all were intradermal or any subcutaneous when you are getting in PDL and scar is there a difference?
It is intradermal.
Both intradermal.
Yes.
Thank you, Dr. Smita. Have you used in other indications besides this scarring?
Alopecia, means androgenetic alopecia.
Have you any experience in the chronic wound healing?
Yes. For venous ulcer, we had tried it.
It is very effective in even the treatment of the chronic wound.
Yes.
No,
It
we
is
are giving in the
helping
treatment of
them.
trophic ulcer, of the
Yes.
leprosy, diabetic, and venous ulcer. It is found in, we done one study at our center and we found it effective in 90% of the cases. At the end of 5 months, even after the single PRF, 90% cases get healed with it. It is very effective in the chronic wound ulcer also. Thank you. Is there any other question?
I just wanted, because I could see your slides, you have shown the differences between the PRF and PRP. In that you have written that activator is needed in PRP. So just I wanted to just make a note. Yeah, activators. Usually for the dermatological purpose, usually activators is not needed because the collagen itself is an activator which is a natural one. But using PRP in other hard tissue like mainly bones and all, of course an activator is needed. And if you use activator, within 1 hour, 95% of the platelets is activated. And it is when you use the natural which we use in the dermatological procedures, it takes 1 to 10 days. So it is slow process and activating more than till 10 days. Just I wanted to discuss. Thank you so much.
Yeah, thank you.
We call upon our next speaker, Dr. Umesh Kumar, to speak on fat grafting.
Dr. Umesh Kumar is a renowned plastic surgeon of our institute. He is presently the head of department of the plastic surgery. His topic is very interesting. He is going to present on the fat grafting.
Good morning, everyone. And I would like to thank the organizers for giving me an opportunity to speak on this topic. So, fat grafting, percutaneous tissue for facial scars and control form. scar occurs as a consequence of a wound healing, which is achieved in 3 stages. Everyone knows about it. But it is a dynamic entity and initiating from a time of injury to a final mature scar. A final mature scar is composed of a disorganized array of filaments. Scar serves as an endpoint of wound healing to physicians. Patients react to it in a more personal way and emotional way, so they keep on coming back and they keep saying that the scar is still left. So a lifelong scar on the body can be a physical and psychological burden, and which can cause social distress to the patient. Scars on exposed part of the body pose a major concern, and a post-burn scar may lead to contracture formation and which can cause physical disability. So scar revision has always been a challenging task for a plastic surgeon, and non-surgical options are present, like we inject corticosteroids, silicone gel sheet and other therapies. But as a surgeon, most of the time we advise scar revisions, and we have to decide whether we have to go for a simple scar excision and primary closure, and when the scar is not along the linear lines, then we can go for Z-plasty. We don't recommend W-plasties, but it is a theoretical thing that W-plasties can also be done. So amongst all these, the non-surgical options are favored by both the patient and the practitioner. Fat grafting has gained popularity for its cosmetic lipofilling property, and the component is adipose-derived stem cells, and these adipocytes have shown the regenerative potential. The study of Pronard in 2013 documented that fat grafting significance in scar rejuvenation. The use of mechanically emulsifying autogenous fat is termed as nanofat. So nanofat, there are two things: either the fat can be injected, or we can distract the fat and only the cells can be used for rejuvenation. So it is nanofat. The nanofat possesses all the properties which the fat possesses, but it does lack the lipophilic property. So autogenous nanofat grafting has become an exciting proposition for scar modulation. One difficulty which we find while doing this injection, this fat and nanofat, is that we find resistance while injecting it. So if we try to eliminate the fat part and use only the liquid part, then it becomes a bit easier. So to make it liquid, to liquefy the fat, there are two things: either a filter can be used or a transverter can be used. The Chen et al. Was the first person to use this transverter. I'll show the photograph of it. And they have used this nanofat even in hypertrophic scars. What are the indications and contraindications? All patients with mature post-traumatic scars can be, we can use it. In post-acne scars, in post-burn hypertrophic scars, the fat graft can be used for augmentation. It can be for face, for example, the upper lip, lower lip, or the chin areas. It can be used in different syndromes, like I'll be showing the facial photographs of hemifacial macrosomia, in lipoatrophy patients, in aged patients who have a post-burn scar over the dorsum of hand, or patients who are having wrinkles over the dorsum of hand and they want to conceal it. It can use, the fat grafting can be used to eliminate it. There are, in certain genital regions also, it can be used for the regeneration. What are the contraindications of it? In patients with unstable scars, malignancies, contractures, and with comorbid condition, and if a patient has an unrealistic expectation, then also we should avoid using fat graft. A very lean thin patient, there is limitation of the donor site, so it can be a contraindication. Preoperatively, patient should be concerned about the procedure and need of repeat sessions if necessary. And documentation is very important in these patients. That is, the location, cause, duration, size, and any previous treatment which was given should be documented. So, what is the technique? A proper aseptic technique should be used, and the donor areas can be the abdominal area, the hip region, the upper thigh, which can be from the medial side, lateral side, or the posterior infratracheal region, and the lower back. And sometimes even the knee region can be used as the donor side. And from harvesting from a donor site, in our cases, we have used the umbilical region so that the scar is hidden, a small incision is given, and 1:1 ratio of wetting solution is injected into it. We wait for the hemostasis for 7 to 10 minutes, And after that, the fat harvest is done with the Coleman cannula, which is around 15 to 23 centimeters in length, and its diameter can be 2 or 3 millimeters. We use Lure-Lock sealing, we connect it with the cannula, and we just gentle push is given, and 2 to 3 ml of gentle backward pressure is applied, and we try to suck the fat. Fat processing can be done in 2 stages. If we have to inject only the fat, then the fat is harvested and then it is transferred into the liquids, and centrifugation is done at 3000 rpm for 3 minutes, and then it is separated into 3 layers: the oil, fat, and the lowermost layer, which contains water, blood, and the fat layer, the middle part is used for injection. But if we want to convert it into a chyle, that is nano fat, then we have to pass it through the transverters and our filter. So the transverter in the second stage, if we want a nano fat, then emulsification is carried out by passing the fat back and forth between 2 syringes about through the transverter can be of 2 types. It can be of 1.4 millimeter size or 0.8 millimeter size, and this has to be done 30 times. And later on, once we do this procedure, a milkish white chyle fat is obtained after this, which is transferred to a 2 or 5 ml Lure-Lock syringe for injection into the scalp. The fat injection is given, for example, if in the face, if we want to inject it, we have to see where the scars will be minimal. For example, the preauricular region, in the temporal region, in the nasolabial region. Actually, at the junction points or in the submandibular region, the incision should be given so that the scar is hidden. And what is the end point of it? A yellowish blanching. If we see yellowish blanching, it means that here we have to stop the injection. Or if we are injecting it for a contour deformity, then if the contour has been overcorrected, then we have to stop. And the evaluation should be done, and we should do proper documentation by taking photograph. So here you can see that on the extreme left, this is the transverter. 2 syringes can be connected. The second cannula, which you can see, is used for injection of the normal saline for 1:1 wetting solution. The third cannula is for harvesting of the fat, and the fourth one, which is for injection of the fat. And the fifth photograph, you can see that there is a Lure-Lock syringe. So when you see the fourth photograph, you can see that the size of the cannula is only 5 to 7 centimeters, and it is blunted. And the fat comes out not from the tip, it comes a bit 2-3 millimeters back from it. So this is the fat which has been centrifuged, and you can see that it is in 3 layers: upper fatty layer, the middle fat which has to be injected, and the lowermost part which contains blood and erythrocytes. And this fat has been transferred into simple syringes, but we'll advise that we should use Lure-Lock syringe, because otherwise when we try to inject it, there will be significant amount of spillage. So to avoid the spillage, we should try to use the Lure-Lock syringe. Now here, this is a 0.8 millimeter transverter. You have already shown it, and you can see that the syringes has been connected on both the sides, and we transfer it 30 times. So it will be converted into a chyle. In the second photograph, you can see that a scab incision has been given in the preauricular region, so that the scar is concealed, and this is how we inject the fat into the desired area. Discussion, most of the things I have already described. The fat graft provides physical support, and it also secretes cytokines which aid in regenerative and metabolic activities. And these cytokines stimulate synthesis of collagenous fiber and promote neovascularization, providing oxygen and nutrition, and thus improving the scar texture. Tonard et al. Introduced the concept of nanofat, which I have already discussed. Now, what the patient observed in the follow-up period is, patient noticed significant improvement in the scar characteristics such as pain, itching, stiffness, thickness, irregularity, and color. We may also observe significant reduction in vascularity, pigmentation, thickness, pliability, and the surface area. One of the most important improvements of fat grafting is improved scar pliability, and the long-term improvement in scar is due to stem cell induced collagen and elastin synthesis and remodeling. The short-term effects is due to the separation of the scar tissue from the underlying structures following injection of the soft fluid fat in between. So now we'll come to the clinical photographs. Here you can see that a depressed scar is present in the malar region, and in the follow-up period you can see that the depressed scar has, because there was little bit of hypopigmentation also in this patient, so we could, by injecting fat, we could improve the appearance and contour of the patient. This is another case where there was hypopigmentation in the cheek area, and here you can see that the area of hypopigmentation as well as the scar quality has improved. This is another case, the patient was referred to us. Here you can see there is a significant contour deformity at the chin area, and we have used fat graft to improve it. This is the initial post-operative period. There was overcorrection was done, and edema is also present in this patient. And this follow-up photograph has been sent by the patient herself, and she is she lives in Bangalore. She had came here to get it improved. This is another case where the patient was suffering from post-burn scar in the cheek region, and we injected the fat graft, and a significant improvement could be achieved in this patient. Because if we want to improve these conditions, we can use tissue expander, but it becomes a very costly affair. The expander itself costs around 45,000, and she has to visit multiple times. 2 to 3 surgeries are required, and in spite of that, a linear scar is always there. So we try to inject fat and try to improve the contour appearance of this patient. This is another dramatic case where the patient is suffering from Romberg's disease. You can see that the facial bones are very prominent, and after injection of the fat, the appearance of the patient and the confidence of the patient has changed. There is another case where the fat grafting was done, and the patient was she short neck and was not a very good candidate for tissue expansion. So we advised her that she should go for fat grafting, and she went for fat grafting, and 80 to 90% improvement in her appearance was achieved. This is the last case. Here the patient has hemifacial atrophy, hemifacial microsomia, as well as she had a cleft involving the Tessier 7 cleft, and here you can see that if you see the right photograph, you can see a linear scar at the from the angle of mouth, and in the follow-up photograph you can see that the significant contour improvement has been achieved. So, and the patient was very much satisfied. These are the initial photographs of 2 months after the injection. We always try to do overcorrection, because it is said in literature that around 50 to 70% of the fat only survives, rest of it is absorbed. So what are the complications which we can encounter? Swelling and bruising is in the initial period. If asepsis is not maintained, then infection can be a very devastating thing. Aesthetic appearance, the patient may say that too much has been injected, or she may say that too less has been injected. So satisfaction index can be different for different patients, and if it is not injected in a proper way, then it can lead to irregularities. A bumpy appearance can be and if we inject, the fat is injected in very small amount, 0.1 ml is injected and it is, we keep on injecting and withdrawing. So it has to be done in multiple areas and multiple levels. Because it is a graft, it has to, its nutrition has to come from the surrounding area. So it has to be injected in very small amount, and if we inject large amount in a particular area, then a central necrosis of the fat can occur, and which can lead to deformity and discomfort. And one of the most dreaded complication is fat embolism. If we keep on pushing the fat and we damage the vessels and we inject the fat, then it can lead to fat embolism, and sometimes one of the dreaded complication is blindness. To conclude, autogenous fat grafting has immense potential in rejuvenation of the mature scar. Given the low morbidity and ease of application into the scars, it can soon be a newer modality in armamentarium of the scar therapies, and future studies are warranted to understand the biological mechanism behind the therapy. Thank you.
Thank you, Dr. Miss, for very informative and interesting presentations. I want to one thing, in most of the cases of acne, we have atrophic scar and sometimes hypertrophic scar. What is your experience regarding in which type of scar do we get the better results?
If there is a contour deformity, sir, definitely this can help. And if we want to inject, because injecting in it is also a tedious thing. If a patient doesn't have just a small depressed scar is there, then I'll advise that we should go for a nano fat grafting rather than a complete fat graft.
In many photographs of most probably some patient may be case of the localized scleroderma in which we get the atrophy. My suggestion is if it will become the stable, because initially patient may have progressive scleroderma. So when you inject this fat transplant,
Actually, sir, these patients,
depending on the durations.
I just cannot comment on the particular duration, but most of the time they are sent from your side only. So once they come from your side, we think that now he is already running behind to get for correction of it. So they come and we just inquire, and one thing is very important, that whether it is not progressing, it is static.
Our suggestion is to just make the condition static,
yes,
then we can go for any process.
Yes.
Okay. Thank you.
Questions from the audience? Need to very inquisitive because such a nice presentations you have, and very nice surgeon. Do you have any experience regarding treating patients with facial hemiatrophy, especially Romberg syndrome? Only sir, just I'm asking. Like,
Madam,
yeah.
because we started in 2019, just before the COVID time. So in initial patient, I was a bit hesitant to overcorrect it. And the patients, though the patient got married and everything happened, but the patient said it reduced in size. But later on, I realized that we should overcorrect it. So in the initial 2-3 months, we explained the patient that we are overcorrecting and this will gradually settle. And the other thing is that we always, before starting the treatment, we say the things are going to be taken from your body and will inject it in your body. So it's not very costly. It's a very cheap affair. If you need, you can again come to us and we can repeat the procedure. But fortunately, since the last 5 years we are doing it, and we did not receive any patient who came back and said, sir, you please re-inject. So most of the patients, when they are satisfied, they never come back. This is the problem. Here follow-up also, they don't come. And once any problem arises, then they come back, and if any patient comes to us, we'll definitely help. I have shown 3 photographs of hemifacial atrophy.
And any patients you have inquired about HIV-related lipodystrophies and all?
No, ma'am.
Oh.
Because handling of fat and all these things is a different thing.
That's why I'm asking, because
it may be a bit tricky.
Yeah. Okay. Thank you, sir, so much. So we call upon our next speaker, Dr. Rashmi Singh, and she will be speaking on fillers in dermatology.
Dr. Rashmi Singh is assistant professor in Heritage Institute of Medical Sciences.
Yesterday, Manas sir has already put a platform for complications in dermatosurgery. So my focus today will be on complications of fillers. So classification of fillers induce complications. It may be a technical error, like too much, if we fill too much of fillers, or too little. Both will cause any kind like deformity or disfigurement of the face, or it may also it won't give a good cosmetic appeal to the patient. Depth, too superficial or too deep. Locations, wrong locations if we put the fillers. Product choice, like inappropriate product if we give like where we have to give a deep filler, high G prime filler, we are giving a low G prime filler, or if we have to give a low G prime filler, we are giving a high G prime filler. Inflammatory cases, inflammatory type of complications also we can get. It may be infectious agents like bacterial, fungal, viral or biofilm mediated, and it may be immune mediated, not related to the infectious agent. So these are the signs and symptoms of accidental intraarterial injections. Pain. Sometimes while we inject, patient winces with pain. So we should become conscious and we should stop and look for any complication. Though pain may be absent initially if the anesthetic agent has been used, which is quite common nowadays. Escalating pain is felt in areas affected by ischemia and may not respond to treatment with analgesics. And clinical consideration, if we see, it is absence of pain is therefore, as I said, it is unreliable in early phases of injury. But yes, we should always stop and think that the patient has suffered any complication or not. Pallor or the blanching phase, blanching of skin may occur. It is the next thing which is seen when we go for an intraarterial injection of filler. It may occur immediately after the intraarterial injection as a temporary phase, though it is again not very pathognomic. Why? Because if pallor may also occur with epinephrine if it is there in the anesthetic formulation and we are using that anesthetic, and it is due to arterial contraction and generally lasts for 5 to 10 minutes. So if it is pallor is there for 5 to 10 minutes, we should again wait and watch and look for the complications. Libido phase, blotchy reddish or the bluish mottled discoloration typically follows the blanching phase but progresses to bluish discoloration as oxygen is depleted in cases of complete occlusion. It is again not very pathognomic. Partial occlusion or presence of collateral circulation can modify the clinical appearance. Also, skin color may be altered by the ambient temperature and modulated by the patient's sensitivity to cold. And this we should be very conscious because we use sometimes the ice cubes or the ice packs for the relieving the pain in such patients while doing the fillers. Libido may be due to capillary dilatation after arterial contraction or after arterial occlusion. Slow capillary refill, digital compression of the affected area, like suppose patient complains of pain while we are injecting the fillers, we can do this digital compression of the affected area which shows slow blood return. Return of normal pain color after 1 to 2 seconds is considered normal, and slow capillary refill may be a sign of arterial insufficiency. Blue or grey blue phase. With local tissue oxygen depletion, the deep blue color of the deoxygenated blood predominates. Metabolic activity in the affected tissues consumes all the available oxygen in the local blood, causing a deep blue black discoloration. Over the time, this may take on a grayish hue. Deep blues may have a similar appearance and it can be a confounding sign. So we have to again be conscious here. Demarcation phase, in the advanced state of the ischemia that has progressed to necrosis, a distinct margin of hyperemia surrounds a zone of frank necrosis. Epithelial integrity is lost and skin slough begins. Localized tissue necrosis is a late sign followed by the tissue slough, often involving the several layers of the tissues. The ulceration that results then heals slowly by secondary intention. Repair in the remodeling phase, this is the last phase if the necrosis has already occurred. Final stages after the slough of necrotic tissue. Inflammation subsides and tissue repair and remodeling occurs. Healing occurs by secondary intention again, and as the epithelial cells migrate and mature to heal the wound. Injection techniques and consequences. Over the time, many filler injection techniques have evolved, which include point-to-point, linear threading, direct deposition. But yes, we have to master our own techniques. Two most important mistakes which the beginners usually make is not priming the filler syringe, which leads to difficulty in pushing the filler and sometimes spillage. Changing the position of the syringe while aspirating is again another common mistake which the beginners make. Aspiration techniques. Keep your hands steady and fix your position first. Changing position by the injector and of needle both can be dangerous. Keep reminding yourself to aspirate as you advance your needle or go retrograde. Count for 10 seconds while aspirating. It is good to aspirate multiple times rather than not aspirating. Choose your own technique and master it. Inject now, but don't be too superficial. Too superficial for a high G prime filler means a total loss. Wastage of filler and green hue on the face, which is due to the Tyndall effect. Filler means filling, it's not always. We fill, we contour, reduce the wrinkles and bring about rejuvenation of the face. It depends on the G prime of the filler. So here are few pictures. So I hadn't my own pictures of any kind of complications of fillers. So I have taken it from the journal, Aesthetic Surgery Journal, from an article, Complications of Injectable Fillers Part 1, and it was written by D. Lorenzi Claudio. And here are the pictures. You can see that we can see the difference. Here the patient has shown the bruising, and at the 3rd, 9th and 24th day after the filler, we can see that the bruise has disappeared by itself. So this is one of the complications which we can revert back. Before and after highlight photo, we can see that the Tyndall effect, mild Tyndall effect is here because of the superficial filler injection, and we can see that after highlights, it has already disappeared. So again, here is a case of 38-year-old women and who presented with a submucosal nodule 1 month after the hyaluronic acid filler treatment. And by puncture, that is incision and drainage, it was performed with a 21 gauge needle, and we can see that the filler is coming out. So this is how we can remove the filler if any nodule formation occurs and the patient complains about it. This is again a case of a 42-year-old woman who received an inappropriate volume of PMMA-based permanent filler and presented to the author with multiple nodules along the vermilion border, you can see here, and no abnormal biopsy confirmation was done with 40 microspheres of filler was there, and no abnormal inflammatory response was seen. Treatment options were limited and patient decided against the surgical excision because of risk of scarring. So in such cases again we can do the highlights, or we have the other option of removing if the patient allows. Biofilm and infection post filler, because in the morning again we had a session by Dr. Rajesh sir, and he focused on biofilm because bacteria can safely hide from the immune defense in their biofilm. Antibiotics cannot reach them. As a result, when conditions are favorable, bacteria can emerge from their planktonic state and re-establish the active infection. The reference of same is given. Treating the granulomatous inflammation. Sometimes after the fillers, recently in our UK group, someone had posted this kind of granuloma formation post-filler, and it was doubted whether it was a granuloma as a part of any immune reaction or it was any kind of infection. So once the diagnosis of granulomatous inflammation has been made, intralesional triamcinolone can be given. The graduated injections of triamcinolone acetonide starting with intralesional injections of 0.1 ml. 0.1 ml can be given. It is like 10 mg per ml of solution, and then increasing the concentration to 20 to 40 mg per ml with repeated injection until effective. Treatment should occur approximately every 4 weeks or as and when required, and the amount of injection should be carefully controlled to prevent the post-treatment soft tissue atrophy. So that should be again kept in mind. Another possible remedy may be 5-fluorouracil, though not much documentation is, not much literature is available. Complications which are difficult to revert, or in fact sometimes we are unable to revert such complications of fillers. So we have to recognize there and then. Lip and nose looks easy, but the most dangerous area to treat because of the high vascular supply. Smaller needles are more dangerous. Using smaller needles for devoluminizing treatments is more dangerous since larger vessels are typically found in the anatomical deeper structures as we do in the this mandible angle area. If we do the fillers, we do directly, we deposit the filler, so we have to be conscious while we are using smaller needles. Larger bore needles tend to either roll out the arteries of the way or side cut them. So they will cause bruising, but they won't penetrate the cleanly into the lumen, and hence won't cause that much harm because bruise can be reverted back. Smaller sharp needles tend to penetrate the vessel wall more easily and thus present a higher risk, especially if the vessel is in a location of restricted mobility. like scars, previous scars can be there. So here is a paper which was published in Aesthetic Plastic Surgery, and it was by Kim G.Y. Eom. And the temporary blindness after an anterior chamber cosmetic filler injection was seen. In 12 cases, vascular occlusion progressed to brain infarction identified by the MRI. 2 were associated with ophthalmic artery occlusion, whereas 8 were associated with retinal artery occlusion, with exception of the 2 cases, one leading to patient's death and another resulting in neurological sequel, that is blindness was the main consequence for all the patients affected by the brain infarction. So we should be very careful while we are doing the upper face fillers. With the exception of 2 cases, one leading to the patient's death and another, this I've already said. Full recovery was reported in 7 cases, 1 case of blindness, 1 of visual loss, 5 cases of vascular occlusion with minor consequences were seen. Temporary blindness was caused by an HA injection in the eyebrow. The patient reported foggy and hazy vision immediately after the filler injection. 10 days later, the filler was successfully removed by irrigation and aspiration after creating a temporal limbal incision in the affected eye. 8 days after the removal, visual activity was restored. Treating the scarred area with fillers. As just mentioned, treating areas of scarring as from previous rhinoplasty or facelift, when arteries may be fixed by surrounding scar tissue, carries a higher risk than treating the unscarred area with fillers. Multiple previous treatments with filler material also can cause buildup of collagenous scar tissue in the treated area. This is clinically self-evident since the patients with a long history of filler treatments often have a gritty subacute observed during the retreatment injections. In fact, this may be the source of long-term improvement seen in rightids of patients with long histories of repeated treatments. What volume of filler can cause the obstruction? It can be anything more than 0.1 ml. So accidental injection of more than 0.1 ml can cause substantial injury, but extent of injury also depends on the vascular structure, the presence or absence of the collaterals, and the filler composition. Injection of smaller quantities does not seem to result in significant arterial blockage in most reasons. However, the reason being treated is a critical consideration. For example, glabella. Whereas 1/10 of a milliliter might not cause any significant problem in an area with abundant collateral circulation, this volume is devastating in the retina. So here is a picture showing filler embolism. This is injection into an artery causes retrograde flow proximal to the central retinal artery's branching point. The filler is then carried forward with a blood flow and eventually causing the obstruction. Patients may present with a sudden blind spot or visual field deficit, fundoscopically a filling defect in the retina. Prevention is the only key in such cases. So we should be very conscious. How does a filler reach artery origin? The retinal artery is a final branch of the ophthalmic artery. So an occlusion of the retinal artery is not likely to have consequences at most central areas. However, when the tip of the needle penetrates the artery and pressure is applied to the plunger, the filler can reverse the flow in it, moving as a column proximal to the origin of the retinal artery. If the injector exerts more pressure on the plunger for a longer time, the column can reach the origin of the ophthalmic artery, and part of the filler embolus can access the internal carotid artery and subsequently reach the cerebral circulation and cause the cerebral infarct. So this is patients sometimes complain of the periorbital edema on day 7 of the periorbital filler injections, which is again a very important concern because they will just call you on phone and disturb you for this. So you should sometimes, if you feel that you have filled a bit more, you should ask the patient, counsel the patient regarding same.
Let us please conclude.
When and where to inject the hyaluronic acid? Only 15 minutes. It is ruled in all the filler-induced obstructions, even a small degree of external compression will allow the material to move subcutaneously. So it is important to keep the material where the obstruction is. Reconstituting the hyaluronidase, the volume of diluent range from 1 to 10 ml. Larger volumes of dilution are recommended when smaller amounts of hyalase are required to allow more precise dosing. Add 1 ml of diluent to the hyalase and ensure that the powder is fully dissolved. So this is a flow chart where in case of vascular occlusion, reconstitution of hyalase is done with 1 to 5 ml of solution. and infiltrate 450 to 1500 units of hyalase over the entire area, including the course of the vessel by serial puncture. And massage and then apply heat. Massaging is very, very important while we are injecting the hyalase. Reassess after 1 hour to ensure capillary refill. It should be less than 4 seconds. And we see that whether it is resolved or not. If not, then we have to go for further cycles. For other indications like Tyndall effect and where the patient wants a reversal of the filler, 5 to 30 units per 0.1 ml of filler can be done. Here is a brief chart of how much to give the hyalase. In nasal and perioral skin it is 15 to 30, periorbital 3 to 4.5, infraorbital 10 to 15 and lower eyelid 1.5. How much to inject? We can calculate with this formula. Hyaluronic, sometimes it has to be taken care of, that hygiene has to be maintained again in this case because it can sometimes lead to spread of infections. There are certain bacteria also like staph, strepto and analobes. They can naturally produce a hyal, and again we are also giving the hyalase, so this both can lead to which it plays a role in their pathogenicity and allows them to spread quickly through the subcutaneous tissues consuming hyaluronate as they go. So take home messages: first, master aspiration technique with intralesional injections. Start with point-to-point technique. Stop when you see the pallor or patient winces with pain. Call the patient and follow up for sure. Be conscious while injecting the T-zone, that is the glabella, nose, nasolabial and lip. Take precaution, master your own technique, but keep injecting. Thank you.
Thank you, Dr. Rashmi. Now we come to the end of this session.
That is dermatosurgery session. Thank you, everyone.
Any question from the audience?
I just wanted to know the risk of this arterial occlusion between platelet fibrin injections when they are giving in the periocular area, like doctor has given a previous presentation, and the hyaluronic acid fillers. Is the risk same?
No, it is different. In PRF, it is a lesser risk as compared to the fillers. Fillers have naturally more risk, especially if we are going for a higher G prime. So we should, in periorbital area, we should avoid the high G primes and we should go for the low G primes.
One small comment I want to make: for the beginners, it's always better to start with cannulas than with injections. Back then we didn't have options, so we always did the needle technique and injection technique. So the risk was much higher. But with cannulas, the risk of injection into the artery is very, very less. Aspiration must be done in certain areas. You should thoroughly know that anatomy, applied anatomy, and the pathway of facial artery. And the beginners should avoid fillers in the upper face. It is always the mid face, lower face, and last should be the upper face. And better go for threads and other techniques for upper face because the risk is very, very high with the intradermal fillers.
Yes, I had mentioned also that smaller bore needles they should be taken care of while injecting. Thank you.
Thank you very much. It was a very nice session. Now we will go to the present chairpersons and speaker. Please come to this corner, and Dr. Dinesh Mathur will present the mementos to them. The next session will come, and over here I would like to request Dr. A.K. Srivastava to chair the session along with Dr. Vimla Manne. Vimla is from Hyderabad. She has a chain of aesthetic clinic in Hyderabad, which is around 19 years she is practicing with lasers. And the first speaker is not present over here, but it will be just a presentation from the laptop, a video presentation by none other than Dr. Uday Khokar from Mumbai. I think most of you know him. And one more thing I would like, because of the young people are here. For presentation, what you do is, what do you call it, award presentation. You show your slide, your name, etc. You have only 5 to 6 minutes time. So when you prepare the slide, suppose it's 7 minutes or 5 minutes, they'll tell you before, or 10 minutes. You prepare the slide, 1 minute, do it, rehearse yourself. It should finish at least 1 minute before. Understand? Now don't read it. The problem is we just, no. Try to tell others. This is what it is. And about the inclusive criteria are blah, blah, blah. No, you're wasting time. The inclusive criteria are, which is given away in the slide. Done. The exclusive criteria are this. Done. One line, few seconds, finish, you get more time. That way you do it. And in a slide, you try to put less amount of words. You want to explain? You do it from your memory. Small things. Write the points. You write the whole thing there. But don't read it. Because when you are reading, your points go down. And if you mumble, then people cannot hear, the guests cannot hear, the judges cannot hear, you waste number. But if you are bold and speak loudly, that goes into the head of the judges, and they might give 1 or 2 marks more. Because if you mumble, nobody can hear, so how will they give the numbers? You keep these things in your mind. Okay, I think next time we'll perform much better. Thank you very much. Now we start. Is it ready? We start the session of Dr. Uday Kokar.
Good morning, everyone. It's wonderful to talk to you about a topic that is close to my heart, that is diagnosis of facial hyperpigmentation with the help of clinical histopathology and dermoscopic correlation. At the outset, I would like to thank the organizers for inviting me for this wonderful conference. I saw the reviews, it's great, and I'm happy to be here with you talking about this condition. So we begin with the beginning, the most common of them, melasma, and we all find it very easy to clinically diagnose melasma. But that's what histopathology, that's what the dermoscopy starts looking in its early phases when you see small granular pigmentation appearing around the follicles, accentuating the reticuloglobular pattern initially in a patchy pattern that tends to coalesce, forming the individual freckle of melasma. And later on, it tries to encircle the globules, which are represented by the follicles. Actually, that gives rise to the curvilinear pigmentation around them, and eventually the jelly sign. This is a little bit more advanced melasma where you can see a little bit Fitzpatrick type macules occurring because of hydroquinone pigmentation. This is a histopathology of epidermal melasma, where the pigmentation is more or less exclusively epidermal. You do see a bit of infiltrate because biopsies in melasma are rarely done in early cases. Most of the times they are done in late cases when it doesn't respond well to treatment. And this is the usual melasma where you have a mixed dermal and epidermal picture. And that's what mixed melasma would look like, where areas of brown pigmentation are mixed with a little bit of darker pigmentation. And larger globules start appearing in the, you can see some larger globules starting to appear because of coalescence of pigment granules, the larger globules that you see here, and encircling of the follicles gives rise to jelly sign. I think it's best seen better later on. Use of steroid creams gives rise to this telangiectasia, so abuse of steroid cream rather gives rise to this telangiectasia in melasma. And this is the so-called jelly sign, where of course you can appreciate the darker nature of pigment over here indicating it's mixed melasma that has been present over longer duration, and that's the so-called jelly sign. In ochronosis, darker pigmentation takes over, which is grayish in color, and at times slightly elevated areas as well as these lighter Fitzpatrick macules are interspersed among the pigmentation. And histopathology shows this so-called banana bodies, the ochre or yellowish brown pigmentation of the collagen that you see over here, typical banana bodies. And on dermoscopy, you have these curvilinear or linear specks, lines which are typical of ochronosis, and these Fitzpatrick macules are represented by areas of hypopigmentation. There's also a bit of reddening because of erythema at places because these patients commonly use combination creams. In lichen planus pigmentosus, it begins in these areas, but if you get a patient with such early lichen planus pigmentosus, you might call yourself unlucky because this patient is liable to progress most of the times, and the patient, it's very difficult to hold such patients because in spite of trying immunosuppressants, they tend to progress. So it's easier to diagnose and hold this more advanced pigmentation cases where the pigmentation tends to coalesce or is diffuse to start with, and at times it does involve the whole face and commonly extends also to the neck and upper trunk. On the neck particularly, we are able to see this very follicular pattern, and on histopathology we see an infiltrate around the upper plexus of lymphocytes predominantly with melanophages that are scattered, and on closer examination you can appreciate that there are colloid bodies at the dermoepidermal junction or macular chain sometimes on the infiltration by lymphocytes depending on the stage of inflammation. In lichen planus pigmentosus, the pigmentation that you see on dermoscopy is in a little bit of darker gray or bluish pigmentation, but sometimes it can be brown as well, but many times the typical pigmentation is dark gray to black or bluish, and it's present in granular or globoid pattern, and it tends to follow appendages giving rise to this M-like pattern. You can see double line of granules parallel to each other over here, as well as over here. That's the typical pattern of, and a similar condition that affects the trunk more often is erythema dyschromicum perstans, which affects the trunk and the extremities more often, and later can affect the face. You may see a fine degree of erythema in these cases. And on histopathology, which is similar to lichen planus pigmentosus, you also see epidermal hyperplasia. You can see a bit of infiltration of lymphocytes at the dermoepidermal junction. And the dermoscopic pattern of acidomatosis is, though similar to lichen planus pigmentosus, it tends to be darker in color with finer granules, and that tend to coalesce, and if you compare it with a bunch of rhododendrons in black and white, gives rise to this rhododendrons pattern on a dark background. So it's particularly seen better towards the periphery of the patch. And occasionally we see cases where they resemble freckles, but they are not present in photo-distributed pattern. Of course, these are the DPN or the dermatosis papulosa nigra lesions. I'm not talking about them. I'm talking about these fainter brown macules. And unless you examine the axilla of this patient or the covered parts, you may not get a clue to diagnosis. And of course, when you see this, it becomes obvious that it is Dowling-Dickos disease, the histopathology of which is absolutely classic. In addition, you may get comedones in addition to the pigmentation and the delicate proliferation of the rete, branched proliferation of the rete, so-called anti-light. And the histopathology is typical, but the dermoscopy is, I would say, even more fascinating with its polyangulated macules of accentuated reticular pigmentation that are typical in this condition. So really fascinating to look at the pictures of this. Acanthosis nigricans, a more vexing and more common problem in these days in youngsters, where you see early acanthosis nigricans commonly affects the forehead, and when it affects the forehead, we frequently label this as frictional melanosis when it is seen only on the forehead, but actually it's early acanthosis nigricans. When it is affecting the rest of the face, it becomes more easy to diagnose, though. And histopathology is characteristic where you see not just slight papillomatosis, but also basket weave orthohyperkeratosis that includes the affection of the infundibula and the acrosyringia. Dermoscopic patterns are also quite typical, the linear cristae cutis pattern and the sulcus cutis pattern, which early on are difficult to identify, but once you get used to them, they become easy to identify. You see particularly around these white globules where you can see curvilinear pattern around them, and on higher power it becomes more obvious. This is more advanced case where you have this cristae cutis and the sulcus cutis curvilinear pattern. The little lower power of the same, but on higher power it becomes more obvious, very easy to diagnose acanthosis nigricans on dermoscopy. It's an important test to do for undiagnosed pigmentation, diffuse pigmentation of the face. So it's very easy to do. You need not do a biopsy. Of course, biopsy does confirm it, but it's an important thing to do. Post-inflammatory hyperpigmentation comes in various forms and various patterns, but the dermoscopy and histopathology remain similar. So important to do these tests to confirm if one is not sure. This is of course transverse nasal groove in this patient. That's a different condition. This is histopathology of post-inflammatory hyperpigmentation, where you have melanophages in small number in addition to perivascular infiltrate and a bit of infiltration of the epidermis with hyperplasia. So in dermoscopy, in post-inflammatory hyperpigmentation, you get patchy, irregular pattern of accentuation of the pseudo-reticular pattern or reticuloglobullar pattern on the face of pigmentation, along with a bit of erythema associated with these, because this is post-inflammatory, so a bit of erythema is part of it. There's also accentuation. Sometimes the pigment may be deep, giving a little bit bluish appearance. And post-acne pigmentation additionally has these scars, closed comedones, microcomedones, and even excoriations, micro-excoriations. Pigmented contact dermatitis is actually just post-inflammatory pigmentation following spongiortic dermatitis, and it can occur most commonly following hair dye allergy, but it can occur in women particularly due to cosmetics. So there you have this fine brown granular pigment around accentuating the reticuloglobular pattern in irregular fashion and associated with blotches of erythema. You can see ill-defined erythema in the background over here, and variable pigmentation depth as well as size. You can see the various size of globules of pigment forming here due to coalescence of granules, and even the color varies according to the depth. Fixed drug eruption is another peculiar form of pigmentation on the face around the orifices, especially the mouth, nose, eye. It tends to occur around them. And this is the clinical picture. We are very familiar with the clinical picture. This is histopathology. Also, we are familiar. In histopathology, when it is biopsy, most of the times the acute inflammatory infiltrate and interface may be missing because we are looking at pigmentation. So you may find clusters of melanophages as against scattered melanophages like this, which you see in lichen planus pigmentosus. But clusters of melanophages deeper in the dermis is typical of fixed drug eruption. And on dermoscopy at the periphery of the patches, especially, we find this bramble bush pattern, which I have pictured here in line diagram, but you can appreciate a bit of that over here as well. This is formed by the irregular curvilinear and branching pattern of pigmentation at the periphery of fixed drug eruption. That's a closer look at that, where you not just have the pigmentation but also areas of erythema in this. Nevus aorta, very easy to diagnose clinically when it is typical, but sometimes when it is atypical, additional investigations may be appropriate. This is case of that, where you obviously see bluish pigmentation in speckled pattern on the cheek. Histopathology shows deeper down melanocytes which are pigmented, dermal melanocytes which are pigmented. So because it's one of the dermal melanocytosis, your nuclei is in this. In addition to pigment, in melanophages, nuclei are not visible, whereas in melanocytes, nuclei are visible. In nevus aorta, the dermoscopic pattern of brown and grey colored or bluish color, or sometimes even greenish tinge to the color of these macules is typical of nevus aorta, and that's what nevus aorta looks like. Look at the bluish background to this. This is atopic post-inflammatory hyperpigmentation. I call it post-inflammatory hyperpigmentation, but in fact you may not see any inflammation or no complaint of pruritus in such patients. You may see only pigmentation, which follows transient erythema in these patients. Around the eyes, around the mouth, these are the areas that are most commonly affected, and this is what patients come with, periocular pigmentation. You need to ask history of atopy in such patients, and on dermoscopy you can demonstrate not just telangiectasia and blotches of erythema, but also typical streaky pattern of pigmentation, which a streaky and curvilinear pattern of pigmentation around hair globules. So basically it's a multi-component pigmentation of erythema, telangiectasia and pigment globules. Seborrheic melanosis also resembles post-inflammatory pigmentation, but occurs in a particular pattern around in the paranasal fold, nasolabial fold, infralabial fold, also maybe around the eyebrows, sometimes on the cheeks, behind the ear, in front of the ear. So various patterns we do come across. So this looks like bilaterally symmetrical nasolabial fold affection, seborrheic melanosis. That's the histopathology, where you have the typical parafollicular parakeratosis in addition to spongiosis and other features. And this is the dermoscopy, where you have not just blotches of erythema, pigmentation of in granular brown pigmentation, which is accentuating the reticulogranular pattern on the face, but also micro scales and blotches of erythema, which indicate active inflammation in this condition. That's about the correlation of dermoscopy and histopathology, as well as clinical in a diagnosis of facial pigmentation. I hope you have found this presentation helpful. I wish you a very good afternoon. Thank you.
Thank you very much for this virtual presentation, Dr. Uday Kumar.
No.
Eminent how would you differentiate a psoriasis from seborrheic dermatitis with the help of dermoscopy? Because we of late there's the picture of psoriasis on the rise, not the typical psoriasis. So anybody could take up that question? Dermoscopy.
I think we are running out of time. So let's come to the second speaker.
I'm inviting the second speaker onto the dais, please.
Brownie is not there. I think the second speaker has left for his flight. And the last speaker of this session is Dr. Tulika Rai, who will speak on glycophils in melasma. I'd request her to maintain the time because the next session people are there to go to airport. We will miss flight otherwise.
Good afternoon, everyone. I'll be discussing about efficacy and safety of glycolic acid peels in melasma. So melasma, as we know, is an acquired hyperpigmentation of the skin, and often it is resistant to the commonly used topical treatment, whether it's triple combination and sunscreen. So we have to use a multi-modality approach to treat patients when they do not respond to the standard topical treatments, and chemical peeling constitutes an acceptable option in the management of melasma along with the topical treatment. So peel helps in improvement of the epidermal component. The dermal component is handled by the ability of the peel to induce the phagocytosis of the stagnant melanin. This is the pathogenesis that is explained. Deep chemical peeling for the dermal component of melasma is not recommended in patients of darker skin color, that is fixed fatted skin type 4 to 6, since it can lead to scarring and severe PIH. Proper patient selection, good counseling, priming of skin and post-peel use of topical therapies is important to give a good outcome and to prevent post-inflammatory hyperpigmentation. So this is a very important step. Counseling is very important, and we should always give the patient a broad spectrum sunscreen with an SPF of 30 or more, and it should be started at the first consultation. So glycolic acid is a hydrophilic reagent. It works by decreasing the keratinocyte cohesion at low concentration and by epidermolysis at higher concentration. The commonly used concentration is between 30 to 70%. 2 to 3 weeks apart, sessions can be given for a series of 4 to 6 sessions, and after that maintenance sessions can also be given. So many studies are available and they have shown good results with glycolic acid peels, and especially if you combine with topical therapies. And you can combine with in the priming you can give 10% glycolic acid in the initial
2 weeks, and then you can start with the pills. You can also use the modified clearance formula. You can use vitamin C, azelaic acid, and adapalene. So many studies are available. Now coming to the literature review, you can see that many studies are available. In the first study that was published in 1997, it was done on 10 Asian women. 20 to 70% glycolic acid pill was given every 3 weeks for a total of 8 sessions, and the priming was done with 10% glycolic acid cream and 2% hydroquinone. They found that there was improvement in the melasma and the fine wrinkling. In the second study, which was published in 2001 in Indian Journal of Dermatology, Venereology and Leprosy, 100 patients with melasma not responding to the conventional depigmenting agents were included. 55 to 75% glycolic acid pills was done in 68 patients, and 10 to 15% trichloroacetic acid pills was done every 15 days for 32 patients. And the response was assessed after 3 months follow-up period, and it was found that the response was rapid and better with TCA, but the side effects were also more with TCA. The third article was published in Indian Journal of Dermatology. They included 25 non-pregnant female patients with a minimum MASI score of 15, 3 sunscreen and 10% glycolic acid lotion at night was given for 2 weeks, 50% glycolic acid peel once per month was given for 3 months, and what they found that the p-value was significant. The epidermal type melasma had better response than the mixed type of melasma. So in another study, 10 female patients were included, and 1% retinoid peel was given on one side of the face, and 70% glycolic acid peel was done on the other side of the face at weekly intervals, and both peels were equally effective and well tolerated. So in another study, 21 Hispanic women with bilateral epidermal and mixed melasma, which was a split phase trial for 8 weeks, 4% hydroquinone cream versus 4% hydroquinone cream combined with 20 to 30% glycolic acid cream every 2 weeks, and along with the sunscreen with SPF 25 was given. No significant difference was found using combination therapy compared with hydroquinone alone. So even hydroquinone was effective, almost equally effective even when it was combined with glycolic acid cream. In another study, 10 patients were included. All patients were put on a maintenance regimen of retinoid, hydroquinone and mometasone furoate to be applied at night along with sunscreen. Serial glycolic acid peels were given at 3 weekly intervals, and the duration was increased after every peel. And it was seen that after 4 peels, 5 patients had greater than 50% improvement in the MASI score, 2 patients had greater than 75%, 3 patients showed fair improvement. Hyperpigmentation, irritation and persistent erythema was seen in 1 patient each. In another study which was published in Journal of Cutaneous and Aesthetic Surgery, the traditional glycolic, it was basically a review, and what they found, the traditional glycolic acid peels proved to be the best both in terms of safety as well as efficacy. Level of evidence was 2:1 with strength of evidence 8. This was the US Preventive Services Task Force levels of evidence for grading clinical trials. In another study which was published in Indian Dermatology Online Journal on 30 patients, 50% TCA peel and 35% glycolic acid peel every 3 weeks for maximum 6 sessions was given, or if clearance of melasma, whichever was earlier. Priming was done with kojic acid 2% or tretinoin 0.2%, and it was seen that 70% participants in the glycolic acid group and 64% in the trichloroacetic acid group showed good or better response. There was no statistical difference between the 2 groups. However, TCA peel caused more discomfort and more adverse effects as compared to the glycolic acid peel. So in another 2 studies which were published recently, 112 patients of 18 to 40 years of age suffering from epidermal melasma, not taking any treatment for melasma for last 4 weeks were included. Total of 6 sessions of each piece with 4-week interval monthly. Post-treatment follow-up was done for 2 months. What they found was glycolic acid showed good efficacy, and lactic acid also showed good efficacy. Efficacy was higher in lactic acid group, but it was not significantly different. In another study, which was published in 2019, 50 new diagnosed patients with melasma were included. 50% glycolic acid, 92% lactic acid was used in the 2 groups, which was given every 2 weeks up to 12 weeks. Priming was done with 2% hydroquinone cream 2 weeks before. Both pills have equal efficacy, but lactic acid pill is better tolerated. So, There are many studies which actually show the efficacy of glycolic acid peel. Chemical peels are an adjunct to the medical therapy. They produce rapid therapeutic effects. They also improve the skin appearance and texture. With good technique, we can get good results even in dark skin patients. So we can go with the very superficial and superficial peels. And glycolic acid peels are well tolerated by most of the patients. We have to be very careful to give good pre-procedure care. Priming is important and post-procedure care should be advised to the patients. So I am sharing the clinical photos of few of my patients. In the first photograph, you can see that the patient has improved. Almost 50% improvement is there with 5 sessions of glycolic acid, 40% gel peel. In the second patient also we can see there is significant improvement. So there is actually a lot, even in our setup we are using glycolic acid peel and we are getting very good results. Thank you.
It was a wonderful talk by doctor. Youngsters, please don't forget glycolic acid peels are equivalent to medical therapy, which she said that conclusion has to be taken as a take-home message. Don't start with peels right away and once the melasma patient comes. And always the mainstay is sunscreens, oral tranexamic acid along with your peels, and definitely glycolic peels are superior because we age, photoaging is common. We age with dyschromias, unlike Caucasians who age by eating clean. So it improves the collagen as well, and that also helps in melasma.
I think this session is over. All the chairperson and the speakers, please go to the corner, and Professor S.K. Singh will present them with the memento. Now we come to the next session, which is very important. That is immunodermatology.
I want to give a set of thanks to Dr. R.N. Datta sir for the given opportunity.
Thank you very much.
Same here, sir.
Dr. Sunil Ghate, Dr. Dinesh Ashati, Dr. Tulika Rai, please come to the podium. And the chairperson will be Dr. Dinesh Mathur.
Well, good afternoon, and without any this thing, let me invite Dr. Sunil Ghate. Dr. Sunil Ghate for Jack Nips, this clinical evidence of off-label indication.
Thank you, sir. Thank you for the introduction. So I shall be speaking on tofacitinib off-label indications. This is the scope of my lecture. I'll be talking about introduction, the JAK-STAT pathway, the pharmacology of tofacitinib, doses and monitoring, use in special populations, adverse effects, off-label uses in dermatology, the clinical cases and conclusions. So JAK inhibitors were developed and discovered and developed by NIH and Pfizer. It was FDA approved in 2012. Tofacitinib is the first FDA approved JAK inhibitor for treatment of autoimmune disease and was initially studied in anti-rejection agent in organ transplantation. It was initially called as casocitinib. Tofacitinib is FDA approved in the treatment of moderate to severe rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, polyarticular course juvenile idiopathic arthritis, and ankylosing spondylosis. So Janus is named after two-headed Roman god. JAKs exist as pairs, and kinase literally means an enzyme to move. There are 4 types of JAKs like JAK1, JAK2, JAK3, and tyrosine kinase TYK2. And there are 6 stat proteins, 7 stat proteins, stat 1, stat 2, stat 3, stat 4, 5A, 5B and stat 6. So I will not go into the detail about this. So there are multiple cytokines, more than 40 cytokines and growth factors which are collectively involved in signal transduction and which can be inhibited by the JAK inhibitors. So JAK1, JAK2, JAK3 and tyrosine kinase 2, they inhibit various cytokines as detailed in this particular slide. So tofacitinib inhibits JAK3 more than JAK1 and JAK2. It selectively inhibits JAK3 which is found in T lymphocytes, B lymphocytes, natural killer cells and the mast cells. It inhibits interferon gamma, IL-10 family and common gamma chain cytokines. Tofacitinib suppresses intracellular signal transduction of common receptors for IL-2, IL-4, IL-9, IL-15, IL-21, etc. So it's a small molecule with a molecular weight of 504 daltons. The peak plasma levels are achieved in about 0.5 to 1 hour. It is 74% bioavailable and the half-life is 3 hours and there is 40% protein binding. The metabolism is hepatic in 70% and 30% in renal excretion. It is mainly metabolized by CYP3A4 and there is less contribution by CYP2C19 like what we were discussing yesterday. So it is metabolized by CYP3A4. The inhibitors will increase the serum levels of tofacitinib, so co-administration at low levels is recommended. The inducers will reduce the serum levels of tofacitinib, so co-administration is not recommended. Immunosuppressive drugs like azathioprine, tacrolimus, cyclosporine, there is added risk of immunosuppression and therefore the co-administration is not recommended. And in dosage is typically it is 5 mg twice a day. That is what we commonly prescribe in our patients. And the patients who are undergoing hemodialysis, the dose should be administered after the dialysis session on the dialysis days. Patients with lymphocyte count less than 500, you should discontinue the use. In pediatric, also nowadays the syrup is available and the dose varies between 2 and 4 mg twice a day. In hepatic or renal impairment, the dose should be halved. That is, one should give half the dose of what we typically give, that is 5 mg twice a day. Here we should be giving 5 mg once a day. And patients with the absolute neutrophil count of less than 500 to 1000, we should interrupt the therapy till the count stabilize. And patients above 1000 cells per millimeter cube, till the time the cells stabilize about 1000 cells per millimeter cube. As I said, the drugs which are potent inhibitors of the CYP3A4 like ketoconazole and fluconazole, the dose should be 5 mg once a day. And patients with hemoglobin less than 8 grams, one should, or there is a drop in hemoglobin of more than 2 grams, one should interrupt the dose till the time hemoglobin value normalizes. There are baseline investigations are to be done like complete blood cell count, serum creatinine, liver function test, fasting lipid profile, HIV, hepatitis C, hepatitis B, serology, Mantoux test, quantiferon TB gold and the XHS. And at 1 month post treatment and every 3 months thereafter, one should repeat CBC, serum creatinine, liver function test and the fasting lipid profile. And for long term use, annual screening for tuberculosis should be performed. And the guidelines for patients with for the risk of tuberculosis. So one should evaluate and test for active infection prior to starting the drug, and then one should screen the patients annually. And latent tuberculosis infection screening is done with quantiferon TB gold test, Mantoux test, and the XHS. And patients who are confirmed to have active TB should not be treated with tofacitinib. Rather, they should be first treated with the multi-drug therapy for tuberculosis as per the nation's protocol, and then only they should be started on tofacitinib therapy. And in patients who have got latent tuberculosis infection, isoniazid therapy should be started, and patients should complete at least 1 month of isoniazid before tofacitinib is started, and the complete course will be 9 months. In view of the modest risk of transaminitis along with isoniazid, frequent monitoring of liver is necessary. And close monitoring for development of signs and symptoms of tuberculosis is warranted even in patients who tested negative for latent TB infections prior to initiating the therapy. There are few adverse effects which we come across like upper respiratory infection, nasopharyngitis, elevated cholesterol levels, headache, upper respiratory infection, increased blood creatinine, phosphokinase, rash, diarrhea, herpes zoster, etc. And there are other adverse effects like hypersensitivity, GI corporation, lab abnormalities like lymphocytopenia, neutropenia, anemia, and raised transaminase levels as well as lipid abnormalities. Now, FDA came up with the black box warning in 2021. It is about active tuberculosis, invasive fungal infections, and major cardiovascular adverse effects. They have also classified this thrombosis risk also as a black box warning. And there is also a risk of malignancy and lymphoproliferative diseases as like other immunosuppressive agents. But this particular paper, they have ruled out the risk of thromboembolism only because of tofacitinib. In special population like pregnancy and lactation, one should avoid use. Geriatric age, one can use it below 65, but above 65, the risk of adverse effect increases. And in males and females with reproductive potential, the use of contraception is recommended, and they have seen reduced fertility in animal studies. In pediatric age, it is approved for 2 years in juvenile arthritis. And in hepatic and renal impairment, we should reduce the dose. In diabetics and immunocompromised status, watch for high risk of infections. And there is this whole list of off-label indications where we can use tofacitinib. I shall be showing some of the cases of mine. I'm not going to go into the details. This is my patient of psoriasis. This was unstable psoriasis. She had received quite a lot of treatment with all the conventional agents, and she was failing. And this particular patient had started on tofacitinib 5 mg twice a day, and see the improvement in about 3.5 months. The psoriasis has healed completely with post-inflammatory hypopigmentation. This is a long-term follow-up. Post-inflammatory hypopigmentation is what you see. The dose was 5 mg twice a day. So complete healing. I mean, when we are giving biology, we will call this as PASI 100 response. Alopecia areata, I am not going to go into the details about. I'll just show you the pictures. This was my patient of alopecia areata. Now this patient had alopecia universalis, and with other agents she had received partial regrowth, and whom I had started on tofacitinib 5 mg twice a day. And this is the response, early response, quite a good response, and this will be maintained for sure. Now this particular patient has alopecia areata for years together. This is about 10 years history of alopecia universalis, and she is doing quite well on tofacitinib 5 mg twice a day. In atopic dermatitis, this was a patient, again, she was failing other agents. Cyclosporine was given, it was giving improvement only for time being, and the disease was coming back. So was with methotrexate, and this girl was put on tofacitinib 5 mg twice a day. And so this is the baseline pictures, and this is the picture after treatment. After treatment, good improvement. I mean, near complete healing of atopic dermatitis with tofacitinib 5 mg twice a day, and we can give it long term like other agents like cyclosporine. In vitiligo, I'll show you another patient of mine. This is a case of vitiligo vulgaris. This is a long duration. She had already received other agents. This is the baseline pictures. Tofacitinib was started. There is not much improvement initially. Late follow-up after about 1 year, and you see quite a good improvement at 1 year of follow-up. And then you see further. This is at the end of 2 years. The tofacitinib was continued for 2 years, and you see the improvement, near complete healing and near complete repigmentation. And this is the latest pictures. What you see, that almost complete repigmentation has happened with tofacitinib, but now here the drug has been given for a long duration of 3 years. In 3 years, vitiligo vulgaris, almost complete repigmentation. So this is before and after at the end of 3 years, before and after here. Other patches have also showed good improvement. This was a patient of atopic dermatitis. This was a patient of lichen planus whom I had given tofacitinib, and there was complete healing at the end of 3 months of treatment. This was a patient of granuloma annulans. This lady was coming to me for about 3 years, and every time she will respond only to steroids. Other agents were failing. And in this particular patient, look at the involvement on the abdomen also. And here I gave tofacitinib This is the baseline picture. And this is at the end of 5 months. It's completely healed with tofacitinib and which has been maintained. Another patient, this is about bullous pemphigoid. We were talking about it yesterday also. I have about 3 cases right now who are taking tofacitinib and it is completely under control with tofacitinib alone. So this is the baseline picture at the end of 3 months. And talking about JAK inhibitors versus biologics. Now, while biologics typically target one single agent cytokine, JAK inhibitors can inhibit multiple cytokines at the same time. There may be unreported potential of generating neutralizing antibodies. The ease of administration and the topical route is what we will prefer JAK inhibitors as well as the cost compared to the biologics. How safe are they? I mean, it's little early for us. About 3 years in the time we have been using JAK inhibitors. Coming to the conclusion, discovery of JAK-STAT pathway and its various cytokine interactions had led to unfolding and understanding of pathogenesis of many inflammatory conditions. Outpour of numerous clinical studies being conducted gives an idea that molecules will have evolution to the finest. Even the advantage of doses convenience and cost-benefit ratio, they do stand to score over the biologics. However, non-selectivity of targets and lack of long-term safety data underscore their ease of use. Benefit to risk analysis and proper counseling and monitoring should be advocated. Thank you all for your patient hearing.
Don't you combine tofacitinib with narrowband UVB for faster results, sir, in vitiligo patients?
That can be done. Unfortunately, I don't have narrowband UVB in my center. See, what I have seen.
I use narrowband with the tofacitinib. It works.
Even I use and it won't take 3 years, sir. Hardly in 3-4 months the response is so good.
Okay, I mean, point to be noted. I don't have narrowband in my practice, so I don't use it. But what I have seen, the areas which are photo exposed, they respond faster compared to the other areas.
In pemphigoid, you only gave tofacitinib or steroid?
That was bullous pemphigoid, not pemphigus. Bullous pemphigoid, only tofacitinib.
No systemic steroid?
No systemic steroid. Patient was failing on systemic steroid. As the steroids were being tapered, the disease was coming back. So here only tofacitinib, 5 mg twice a day.
And the remission was found in?
No, 3 months the patient has improved and the patient is continuing the drug.
How long do you expect to give?
I mean, after some time I will try and reduce it to 5 mg once a day. I mean, that is what you will do with all other immunosuppressors.
Okay.
Be it psoriasis or anywhere else.
Thank you.
Thank you.
Is there a panel discussion also in this?
No, it's gone.
Finish. Thank you.
Thank you very much. Is the last session of the conference or what?
नहीं, अभी बहुत है.
अभी है ना? Free lunch. Okay. So I got the pride of inviting you to the lunch.
Okay, thank you. Thank you very much for the beautiful session. The chairperson and the speaker can go to the corner, and Professor Deeptara Pathak will give you the mementos. Now, the lunch is ready. It's yet hot yet. You go there and you can come back around 2 o'clock or 1 hour, and the prize will be given during the valedictory after all the things are finished. Okay, ठीक है चलो. At 1:45 to 2.
You can catch the flight.
Yeah, you can catch the flight. So please go for lunch.